Hang on. I've just got to find the. Before you do anything, I'm going to start recording now, okay? Are you ready?
Okay, I'm ready.
Right, you should see the 3, 2, 1.
Yep.
Okay.
So, Dr. Maki, I thank you so much for doing this for us. My name is Ivan Pacheco. I'm a pathologist in Canada, Ontario, and Owen Sound. I'm an anatomical pathologist and doing some hematopathology. I am an adjunct professor at Western University, London. And I'm going to start meeting people here while we are talking. In the Zoom platform, I'm going to be live streaming if everything goes fine through Facebook to your Maki Derm group, and people are going to be able to be seeing you right now. So I have to manually introduce them into the webinar.
Okay.
It's a very exciting experience for me. I haven't done this before, broadcasting simultaneously, but I suppose that you must be very used to this, Dr. Maki.
Well, I've certainly had some experience with it, and it hasn't always been good. I think we are to some extent venturing into fairly new territory, and to be broadcasting a webinar through Zoom and live streaming on McKeederm is quite a challenge, and I'm hoping that it works perfectly and we have no internet interruptions or any other form of chaos.
So up to right now, we have 39 participants that are getting introduced. You could see them now. They are showing up on one of the first people that I saw there was one of my colleagues and friends from my work, Dr. Sore Afshar. Hi, Sore.
So when would you like me to start?
Yeah, the people are still joining. It's automatically joining everybody, Dr. Maki.
Okay. But I'll have a sip of coffee while we're waiting.
And we are live on Facebook right now, so people know what kind of coffee you drink, Dr. Maki.
Oh, gosh.
So I see some people that I know here joining. Dr. Julio Salamanca, he's from Nicaragua. So the idea was to, I have a small group of pathologists I'm originally from Nicaragua, that hi, Dr. Salamanca, that basically we keep on a weekly or bi-weekly meeting conferences, and we try to interact, sharing cases that are difficult. And then during this COVID pandemic, I thought, oh my God, this is really, really depressing. And I saw you, and actually being a member of your group for a long time, I think already. I've been seeing you all this time, and I see how many beautiful, exciting cases, how easy make everything that is so difficult to my eyes. And I said, well, what if I invite Dr. Maki to give a talk for my little group? But then the thing spirals out of control, and it becomes a big thing because your name is attached to many big things such as books and melanoma books, books in dermatopathology. And I think who doesn't know your name now is somebody that hasn't been picking up the library books, the recent library books that keep on changing. And it doesn't do dermatology basically, but I think all the pathologists here right now, they actually do dermatology. So we are different type of pathologists. We all have different degrees. And I ask you if you'll be kind enough to give us a talk, and you agree. And I thank you from the bottom of my heart. And know that you're a very busy person because your group has around how many members? 15.2 thousand people.
Something of that order, yes. It's a lot.
And every time I open my Facebook page, the only place I go is to your Facebook page because you learn every day. The rare things there are common, and every day you learn more and more from you. And every time that I see your comments, say, why didn't I think of that? So basically, I hope that live stream is picking up right now in the Facebook page, but I think that having said this, Dr. McKee has been an active pathologist since 1972. Sorry, 1978. He
No,
graduated.
72 is correct.
72. He was
I
he
was
started
trained.
medicine at Queen's University at Bedford, Northern Ireland. And you will follow training at Royal Victoria Hospital, Belfast, and you became a member of the Royal College of Pathologists in 1978. You did your fellowship at St. John's Hospitals in London, and then you became appointed faculty at St. Thomas Hospital Medical School in London in 1979. And is followed by an illustrious career that includes being a professor in Harvard University, and then you decided to move to Colorado, where you were racing Ferrari vehicles, 150 mile an hour in empty roads, something like that, right?
Something like that.
Yeah, so it's needless to introduce you as, except for the people that don't know you, that they're not doing derm pumps directly. But to me, you are one of the few people that I can actually pick up the books and think that I am seeing you writing the paper, the books, the chapters. So spectacular just to go and read your books. Spectacular to read your Melanocytic Lesions Atlas. I have it by the side of my desk, and I'm very proud to be able to join this group of international pathologists, and that you're gonna bless us with your lecture. I don't know how much else can I introduce you.
I think you've done me proud. So I think I'll start now. I gave this talk back to basics because I thought it would be useful for the audience, who are, after all, from a very varying range of experience, that I would just go back to the very beginning and talk to you about how I think about melanocytic lesions. And to do that, I think it's very important that one pays great attention to the clinical features, because the clinical information should be the starting point when you start looking at any case, whether it's general pathology or dermatopathology. But in the context of dermatopathology, it's important to recognize that the dermatologist is looking at the gross pathology. And so when he or she does a biopsy, we need to know what he or she was looking at, because that is going to affect how we approach the lesion. And so back to basics, the clinical features give insight into the big picture. And I find myself absolutely fascinated with astrophysics and cosmology and the like, and I couldn't resist but put in this slide. I think it just perfectly illustrates what the big picture really is. Now, I wanted to start with these two images. One of the problems with melanocytic pathology is that people do not come from the same position when they're looking at a tumor. They use this book or that book, or they don't use books at all, or somebody told them something so they believe that. And what I want to do is to persuade everybody, to persuade everyone that we all use the same system of classification. And I think the best system of classification is going to be the most recent WHO Blue Book on skin tumors. And in particular, obviously, the chapter on melanocytic pathology. because if we all use that book as our basis for diagnosing these lesions, we will all be coming from the same place. And if we're all coming from the same place, it'll make life much easier for all of us. And then on the left side, I copied the introductory sentence, which reads as follows: despite the advent of large-scale and high-resolution genomics, the gold standard for melanoma diagnosis continues to be histopathology, which also remains the primary tool for classification in conjunction with clinical characteristics. So what that really means is that what you see down the microscope on the H&E, that is the basis for diagnosing melanocytic lesions. You may well, from time to time, use immunohistochemistry, and that may prove useful, or sometimes it may prove not useful. And obviously nowadays we use ancillary techniques such as FISH, comparative genomic hybridization, Singer sequencing, next generation sequencing, and the like. And that obviously also provides invaluable information. But the problem is, despite all of that, despite the histology and all of the molecular techniques that we have available at our fingertips, we still haven't quite reached the point where we know in a difficult case whether a lesion actually is a melanoma or not. We're a lot closer than we were when I started training, but we still have a little bit to go before we're going to be in a position where we can consistently look down the microscope at a difficult, problematical lesion and use all the techniques that are available and come to an utterly reliable, definitive diagnosis. And I'll explain a bit more about that later. Now, I think it's really important for dermatopathologists and pathologists to know something about dermatology, in particular, for example, when we're looking at melanocytic lesions. And I copied this beautiful picture on the right top side. It's courtesy of the National Health Service in the UK. And it beautifully illustrates the asymmetry, the A, the border irregularity, B, the color variation, C, of the ABCDE criteria that dermatologists use when they think about melanocytic lesions. Here you can see it's extremely irregular. It's very asymmetrical, and the color varies. There's a natural skin, so it's slightly brown there, it's more brown there, it's got much browner, and there it's black. And there's also an erythematous component, which is due to increased vascularity. We don't know the size of this, and we don't have the history, so we don't know whether it's evolving or not. But nevertheless, on the basis of the A, B, and C, I don't think anybody should have any hesitation when looking at that lesion to say, oh, that's a melanoma. It's clearly a melanoma. Now, the dermatologists have additional techniques that they can use. And recently, or in the last 20 years or so, dermoscopy has become extremely important. Now, I personally have no experience of dermoscopy. I recognize that it's extremely important, and I recognize that dermatologists use it in conjunction with the clinical features. And when you add those two together, the degree of accuracy of their diagnosis is very high. And more recently, we've seen the introduction of confocal microscopy, which enables a physician to assess not only the borders of the lesion, but the actual depth of the lesion for superficial melanocytic issues. And the combination of clinical features, dermoscopy, and confocal microscopy has made enormous strides in the clinical approach to the study of melanocytic lesions. And in fact, we've almost been relegated to redundant, except that obviously we're of use in measuring tumor thickness and the various parameters that are of importance in the prognosis of melanoma. I want to stress the importance of knowing the age of the patient. This is a critical piece of information. Otherwise, you will make a diagnosis of melanoma in a neonatal nevus very easily. We need to know the sex of the patient. Females when they get pregnant may develop quite marked mitotic activity in the dermal component of a compound nevus. So if you see a nevus with 4 or 5 mitotic figures, it's very important that you check whether A, the patient is female, and B, whether she's pregnant or not. Site of the lesion is again important. If you know that the nevus the melanocytic lesion represents an irregular pigmented melanocytic lesion of the vulva of an 18-year-old girl, you know before you start it's going to be a genital type nevus. It's not going to be a melanoma. So a site is critical. And last but not least, I think it's very important that the pathologist find out the reason the clinician biopsied the lesion in the first place, because if you know that this lesion was evolving and that it was a macular lesion which developed a nodule towards one edge, and they've worried about this nodule, when you view the histology, you've got to make sure that you can see that nodule. And if you can't, you need to do levels until you find the nodule, and then you can explain in your report what it was that caused the clinician concern. Now, I know I live in a very fortunate situation because, hang on, I have to go back. Because I was in a position to ensure that I got all of this information when I worked at Brigham and Women's Hospital, which was part of the partners organization. Brigham and Women's Hospital was linked with Mass General, and we brought in a policy that specimens that were coming in for histology had to have adequate clinical information. And if they didn't have adequate clinical information, then the specimen would not be given an accession number. It would be sat on a shelf in the cut-up room until such time as the clinician got in contact about the case and filled in the form accordingly. And a consequence of that was that it didn't take too long before I always had that information, which made life much easier.
Dr. McKay?
Now, yes?
Some people here in the chat, they're saying, how often do you get clinical information and the pictures of the biopsy? Dr. Salamanca from Nicaragua. What would you actually recommend to people they don't have access to that, or they did not get a picture, they did not get the clinical information?
Well, I was going to say it's a difficult situation, but Here's the problem. When you look at a melanocytic lesion, if you do not know the clinical information, then you're putting yourself and the patient at great risk. So to my mind, you must get that clinical information. And if your dermatologist or the physician hasn't given you the information, then it's your job to make sure that he or she does. I personally would not report a melanocytic lesion or any other specimen for that matter without clinical information. I would just put it to the side and say, sorry, I can't do it, I'm not going to do it. Now, I know that makes life very difficult for people in private practice, but you know, physicians can be trained. And if you train them from the word go that they've got to do this, it doesn't take very long before they catch on and they start doing it. So to my mind, you must always have that information. You've got to make the clinician give you the information, and you have to, it's your job to get it.
Thank you.
So what is, and you see here on the left, I've listed what can go wrong. And I mentioned, for example, the neonatal nevus. If you look at a neonatal nevus histologically with no clinical information, the chances are quite likely you'll call it a melanoma. And you don't want to make a diagnosis of a melanoma in a 6-month-old baby. It would be a terrible mistake to make. It would hurt the patient enormously. And then when the case gets reviewed, you will look very foolish and the clinicians will lose confidence in you. And if it happens to you a whole bunch of times, you lose confidence in yourself. On top of that, you'll get sued. And if you get sued often enough, you'll take early retirement and live a life of depression. And this picture at the bottom, you see where he's sawing the branch. The clinical information is on the right and he's on the left. And when he saws through that branch, he's given himself no clinical information. So he is in real trouble. Now, I think it's important to get some perspective about melanocytic pathology. And when I look at a case, as I've mentioned, I know the age of the patient, I know the sex of the patient, and I know the site of the lesion. And so if you start off with, let us say, a melanocytic lesion from a 13 or 14-year-old teenager, the starting point must be, this is benign. I will do everything in my power histologically to keep it benign. If I'm going to call it melanoma, I'm going to have to work extremely hard to get to a diagnosis of melanoma in a 14-year-old. And if I'm going to call it a melanoma, then I think I should show it to other people and perhaps even better, get an expert consultation, get a good second opinion before you make a diagnosis of melanoma in a young person. And you can see here, this is from the Pediatric Health article in 2017. The incidence of melanoma in a child age 1 in 4 is roughly speaking 1 in a million. So the chances of you as an individual getting a melanoma in a 1 or 2-year-old in 1 year is so remote. It's almost unheard of. Now, the problem, of course, is for someone like myself, and where I spend a lot of time looking at consultations, I see quite a few of them because I'm seeing quite a few from all around the world. And so I'll maybe in 1 year, I might see 10. And then I think to myself, gosh, I'm seeing an awful lot of childhood melanomas. But then I have to go back to this fact and remind myself that this is consultation bias. It's not a reflection of the true incidence. And then when you go up to the teenage years, it increases to roughly 10 per million of the population, or 1 in 100,000 teenagers will get a melanoma. That's still very rare. And it makes the point that you need to be awfully careful before you come to a diagnosis of a melanoma in a teenager. Now, obviously, if you're looking at a melanocytic lesion from the back of a 50-year-old male that's worried the clinician, then your starting point is the opposite way around. You'll say to yourself, gosh, 50-year-old male, pigmented lesion on the back. I suppose this is probably a melanoma, or it might be a dysplastic nevus. And you work that way around. And if you're going to call it benign, you have to work very hard to make sure that it really is benign and that you're not underdiagnosing a melanoma. And that brings me to the point, it's as important to not diagnose a nevus as a melanoma as it is to call a melanoma a nevus. Both mistakes have profound consequences for the patient. Now, here's the question that I think we have to start with, and that is, why are melanocytic lesions so difficult? And I think part of the answer is they've almost pushed themselves into a corner before they even start looking at a case. Because at the end of the day, there are a limited number of entities in melanocytic pathology. They're all very well documented in multiple textbooks, and I refer you to the WHO one so that we all use the same thing. And if we all use the same criteria when we're making a diagnosis, then melanocytic pathology shouldn't be so difficult at all. It's because people don't follow the rules that are given in the diagnosis of a particular lesion that we get all of this confusion. So that's part of the problem. The second, and it's extremely important problem, is the biopsy technique. And I'm going to spend a little bit of time on that in a moment or two. So I'm not going to discuss that right now. The literature is a source of intense confusion. And that's because people are perpetually writing up a series of entity X, and they give it a new name. And so you end up with 10 names for the same thing. And unless you know all of those synonyms, you don't appreciate that they're all the same thing. And that causes an awful lot of confusion. And I just wish people would stop inventing new names for entities that are well recognized. And obviously the third thing is that people are worried, particularly in the States, but elsewhere in the world, they're worried about litigation. And this all really is a reflection greatly of biopsy technique. And on the right, I have a nice photograph here to make the point to you. You see, if you look at that skin tumor, if you can sort of forget that it's from a baby, because you can see that from the overall picture, if you focus on that bit there, you would say, gosh, that's a melanoma. I mean, it's ulcerated, it's huge, it's irregular, it's variably pigmented, and so on. That, in fact, turned out to be a proliferation nodule in a giant congenital nevus, which involved literally 50% of that child's body. And the child had dozens of proliferation nodules, but with the passage of time, they all shrank, and eventually that vanished. And so knowing the clinical information in this baby would have prevented you from making a diagnosis of melanoma.
Dr.
So,
McKee?
yes, indeed.
There is one person here, Marble Taike, that she would like to ask you a question.
Sure.
Go ahead, Marble. Hello. She's not talking, so probably she went shy.
Oh, well,
okay.
let me say to everybody, please don't be shy. I'm actually quite a gentle person, and I'm very happy to answer any questions you like. And if you disagree with me, that's not a problem either, because I can only talk about what I think. It doesn't mean necessarily that everybody agrees with me, nor do I expect them to.
Now, anybody can also type in the Zoom group chat or in Facebook. I'm reading simultaneously and trying to answer any questions by reading them. I did that already. Thank you.
Okay, well, I should go back to where I was now. This is a slide I made in 2007, but it hasn't changed. When I was training in pathology, and when I was working at St. John's Hospital for Diseases of the Skin in London, when the dermatologist was looking at a patient with a melanocytic lesion, one of two things happened. They looked at it and they either said, well, it's a benign nevus, and they forgot about it and sent the patient home, or they would look at it and say, that's a mighty queer looking pigmented lesion. I'd better send it for pathology. And what they did was they either did a circular excision, or if you like, an excisional biopsy, if you want to call it that, or they did an elliptical excisional technique. So when I was in the UK, I never had a lesion which involved margins. And that was because they didn't use the shave and they didn't use punch biopsies for melanocytic lesions. Now, the problem is if you use a shave biopsy or you use a punch biopsy, almost by definition, you won't see the whole lesion, and that causes absolute chaos. And here is a little diagram that I got made, and this is a melanocytic lesion on top, and there's a shave biopsy. That's the plane of section that a shave biopsy would give. And here's the histopathology. The shave biopsy would have come through this bit here. And so you'd have thought it was dysplastic nevus or something, sorry. Whoops, I have to. You might have thought it was a dysplastic nevus or in situ melanoma, but when you look at the bottom two images, you can see this great big nodule in the superficial reticular dermis. This is a nodule of invasive melanoma that would have been missed with a shave biopsy. And the same problem exists with punch biopsies. The same problem exists with incisional biopsies because you don't have the whole lesion. So I preached to the choir all of my life that physicians, dermatologists should not shave or do a punch biopsy of a melanocytic lesion, and they should always do an excisional biopsy. The problem is I live in a world where there is no such thing as cosmetics. I don't care about cosmetics because my job is to diagnose melanoma or to make sure that a lesion isn't a melanoma. That's the only role that I serve. That's my function. And that's the function of every dermatopathologist in the context of melanocytic pathology. And so if you start worrying about cosmetic outcomes, you're going to end up with a perpetuation of a problem, which is that you cannot make a definitive diagnosis because you don't have the whole lesion. And here are some examples. Now, this is a shave biopsy. It's of a dysplastic nevus, which is a whole topic I'm going to talk about in the second lecture. I'm not going to discuss it today, but I use it purely as an example to show you that it's a very generous shave biopsy. I'll grant the clinicians that. But here is the bottom right-hand corner. There is the ink along the inked margin, and you can see dysplastic nevus going right to the inked margin. And therefore, although you can comment on what you see here and there, you don't know what's there. You don't know what's there. You don't know what's there. And so inevitably, you're going to have to ask for a re-excision. The re-excision then causes the same cosmetic issue that would have been a result of excising it properly in the first place. So all you've done is you've done a punch biopsy, and then you have to go back and cut it out again, which is a terrible waste of everybody's time. Here's another one. This is another, and again, it looks an awfully good shave biopsy. And you can see there's, I mean, even at this magnification, I think you can tell there's melanoma in situ. There's pagetoid spread very clearly seen in the epidermis. But there's the problem. You come to the edge of that lesion, and there you see in situ melanoma with pagetoid spread. There's a nest of atypical melanocytes. There's probably pagetoid spread right at the edge. And so this lesion has got to get re-excised too. And here is another one. This is a shave biopsy. We can tell there's something worrisome. It's unfortunate, it's got rather pixelated, but you can make out there's something going on in the dermis that is not altogether something you want to see. And this bit looks like a dysplastic nevus, but if we move along, you can see that there's a dermal component, and there are very large tumor cells in the dermis with huge nucleoli. This is invasive melanoma, and so that lesion has to get re-excised too. And here's the last one. This is fully fledged melanoma going right to the base of the shave biopsy. And it's beyond my comprehension why anybody would have shaved this in the first place, because clinically, this must have obviously been very palpable, and therefore, clearly, it should have been fully excised. And I don't get it, but that's life. There's a close-up view of the melanoma. So now this, I think, is really interesting. This, I haven't updated this because I didn't think about it, I suppose. But in 2001, Neil Crowson, Cynthia Magro, and my great friend Marty Mim, you know, there are I've had lots of people that I've looked up to over the years in terms of studying melanocytic pathology. Dick Sagerbiel, Phil Lebois, David Elder have all had a major influence on me, as has Ray Barnhill. And most of all, I think Marty Mim from, he was at Mass General, he's now at Brigham, and he's a delightful man, and he's such an experienced dermatopathologist in many areas of expertise, particularly melanocytic lesions. And this is his quotation: "It is our consummate recommendation that any lesion that is suspicious enough to be removed be excised rather than biopsied." And yet, 2001, I was working at Brigham and Women's Hospital in Boston, and I almost never got a lesion excised rather than biopsied. And similarly, in cancer of the skin, Doctors Lee, Gorman, and Swanson, melanocytic should be removed with an excisional biopsy in order to obtain the most accurate diagnosis and prognostic factors. And so what we really have is we have an issue that lies between the dermatologist and the pathologist. The dermatologist has the issue of cosmetic end result of treating a melanocytic lesion. The pathologist is looking at it from the opposite way around because he or she is not interested in the cosmetic effect at all. We're interested only in the diagnosis. Now, I've forgotten why. Oh, yes, this is I just put this in. This is the sort of lesion that even this isn't great. This was an excisional biopsy, and you can see it's very close. The margin, I couldn't get it all in, but the margin is very close there. And on this side, it actually involved the margin. So it's not great. And this is the sort of biopsy that I like. And I do agree, you can't excise a lesion like this from somebody's face. Even I, with my obsession with margins, appreciate this. But this is a case that Antonina Kalmakova shared with me, and this is a huge excision of a balloon cell melanoma of the back. This is not the margin. The margin's way out there somewhere. Just that's the way it cut in terms of for the scanner. So this was completely excised with about ½ an inch on either side. So that's the sort of thing I like to see when at all possible. So the disadvantages of incomplete biopsies, well, they're self-evident. The most important one is the second one. You end up not being able to diagnose the lesion. You don't know whether it's a Spitz-Nevis, or is it a nevoid melanoma, or is it a melanoma, or is it not a melanoma? It's a problem. And if the lesion is sufficiently large, the bit you get may not be representative of the rest of the lesion, so you won't know what's going on in the bit that's left behind in the patient. So the consequence of that is the perpetual need for re-excisions. And if it is a melanoma and you only have part of it, you can't give the information that the clinician and the oncologist need in terms of treating the patient, because you won't know whether what the tumor thickness is and so on and so forth. People don't do sentinel node biopsies so much anymore, but it used to be in my day that sentinel node biopsy was almost always took place for any melanoma that was greater than 1 millimeter in thickness. And so if you only got part of the melanoma, you had to assume that it was at least 1 millimeter. So the patient got a sentinel node biopsy. And the other problem is, if you partially excise a banal nevus and it recurs and the pathologist doesn't know that it had been a previous biopsy, there's always the risk of a misdiagnosis of melanoma. So now I have a couple of little anecdotes to tell you before we move on. And this is a story that I like to call it the story of the unknown scar, or the mystery of the scar in the ear. And this was a patient, and obviously this is not the patient. BBC.com very kindly lent me this picture, or I borrowed it from them, just to make the point that the specimen we received was an ear. And the resident called me down to the cut-up room and asked me, could I have a look at this specimen? So I said, sure, and I came down, and there was this whole ear with a good 1 centimeter of adjacent skin. Excuse me, with an adjacent 1 centimeter margin of periauricular skin. And you couldn't tell an awful lot from looking at it. So I said to the resident, well, what information do you have? And the resident said, well, I don't have any information. And I called the surgeon, and the surgeon only works 2 days a week at our hospital and is not there. So I don't know what the reason for. So in this case, obviously the telephone didn't help us very much. So anyway, I said to the resident, well, you better put the whole thing in then, and we'll look at it and see what the histology shows. So several days later, we got about 50 or 60 glass slides from this blessed ear. And here you can see a scanning view of one part of the specimen, and this is the auricular cartilage, and you can see what looks like scar tissue extending from the reticular dermis all the way down to the depth of the specimen. And again, there's the auricular cartilage at the top, and here's what looks like scar tissue. Now, the only thing that I would say is I think it's important to pay attention to detail. And the detail in this slide is not the scar tissue, it's these aggregates of lymphocytes. They are telling you something. Now, they may be telling you nothing terribly useful, or they may be giving you a clue. And we'll get to that in a moment. So if we look at slightly higher magnification, there is the lymphoid aggregate. This does look like scar tissue, I think, but we've got those lymphocytes to think about. And there's a close-up view showing what could be myofibroblasts. Another view there. And here's a mitosis. None of that is pointing particularly into one diagnosis, but I worried about the lymphocytic infiltrate. That was my major concern. And so we did an S100 protein, and that's nerve, but this is the so-called scar tissue. There are the lymphoid aggregates, and this is all melanoma. So the point I'm trying to make, and I hope I'm succeeding in making it, is never, never, ever report on a specimen of scar tissue if you don't know why the patient had a has a scar in the first place. And then the second anecdote, which is equally important, is always look at all of the tissue on a slide. And that's something you have to really guard against, particularly late afternoon towards the end of the week. Let's say it's Friday afternoon, you've had a very hard week, you've worked 14 hours a day from Monday to Thursday, and it's 6 o'clock on Friday, and you get this case, and there are 5 pieces of tissue on it, but you didn't notice there were 5, and you only thought there were 4, so you missed the 5th piece. That is potential catastrophe. So this was a case I saw in consultation, and it was a teenager with a congenital nevus clinically on the scalp, and it had been reported as a congenital nevus. So at that point, everybody was quite happy about it. And if you can see my arrow clearly, if I draw a line diagonally through the lesion, through the middle of it, you can see that that middle bit has a look of a congenital nevus. But there are things that should be concerning you, and that is this infiltrate here and the infiltrate on the other side. They're different. They don't look like this middle bit. And the other thing, there are these lymphoid aggregates, which, as I was saying to you earlier, they're always a clue to something. So this is that diagonal I was talking about. So this looks like a nevus, and there is deep, 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 deep. And these are type A cells, there are type B cells, and these are almost spindly type C cells. So on those 2 images, sure, it's a congenital nevus, no problem. But then we, there's another view showing this again. If you look at it without thinking too much, you think that's probably congenital nevus. Yeah, that's okay. But if on the right-hand side you look carefully, this is from deep down, and you'll see that the nevus, if it was a nevus cells, they're still big, and they've got rather prominent nucleoli. So that should start worrying you that perhaps this is not a nevus at all. And then we go back, and remember in the first slide, I showed you this different population there. This is the nevoidy bit, and this is the bit that worried me. And there's the lymphoid aggregate. And then we go again. There's this bit that looks nevoid. This bit most certainly doesn't. This is a high power of the left-hand lower quadrant. Here you can see clear melanoma with great big nuclei, great big red nucleoli. And the lesion was teeming with mitoses all over the place. And I've just taken a photograph of 2 of them. And that most unfortunate young man, he returned 6 months later with lung, bone, and I think he had liver metastases, and he died. So really what we were looking at was melanoma arising in a congenital nevus. And the moral of the story is make sure you look at all of the tissue in a specimen. Now, when we're talking about benign melanocytic lesions of any type you happen to think of, one of the descriptive terms that is constantly used is cytological atypia. And that causes people an immense degree of confusion. And I just wanted to show you, if we look at the word atypical, these are the synonyms, and you can see there are dozens and dozens of them. Unusual, non-typical, uncommon, abnormal, aberrant, exceptional, out of the ordinary, off the wall, wacko I particularly like, and kinky. So one has to decide for oneself what is a typical nevus. And when we know what a typical nevus is, then we will recognize everything that is not typical. And so the banal nevus is the typical nevus, and all of the other nevi that we name, whether they're dysplastic, neonatal, genital, nevus of special site, recurrent, Spitz, whatever, they are all atypical because they do not show the features of a typical nevus, of which the banal junctional lentiginous junction or lentiginous compound or compound nevus is the prototype. And so, as I've mentioned, all nevi which aren't typical show some sort of atypia, whether it's architectural or cytological is another matter. And these are all of the nevi which may show cytological atypia. And I'm going to get back to what cytological atypia is later in my talk, but I just wanted to make the point that by definition, dysplastic nevi always show cytological atypia. If there is no cytological atypia, a lesion, a nevus is by definition not dysplastic. And then all of these other nevi may show varying degrees of cytological atypia. And I'm going to talk, most of my talk today is going to be on the Spitz nevus. But on the right here, this is a nice example of a recurrent nevus. You can tell it's recurrent because there's a great big deep dermal nevus with scar tissue. It almost looks like a hypertrophic scar on top, and then there's junction activity. But this scar, which is in the middle of the lesion, and the lesion extends both ways with the scar in the middle, that tells you before you even start that you're looking at a recurrent nevus. Now, I wanted to show this case to you. It's very kindly shared with me by Patrick Emanuel from Peru, who's one of our members and administrators from McKeederm. And that just reminds me, I forgot to say hello to everybody. And in particular, I do want to say hello to all of the members of McKeederm who've joined us. And I want to thank them because without your contributions to McKeederm, I would not have the majority of the images that I'm going to be using in these 4 lectures. They're all courtesy of you, and I am so grateful to you for sharing this wonderful material. So thank you very, very much. And this case is important because it brings the point that I have to bring to you, which is you must always beware expansile dermal nodules. And so if you look at what you think is a nevus, and at this magnification on the left-hand side, it looks like a nevus, but on the right-hand side, you've got these great big nodules. You don't need at times anything objective. You could look at that, hold it up to the light, and you will see those. And that by definition is a melanoma because it's got dermal nodules. The only exception to the rule about dermal nodules is the proliferative or proliferation nodule in a congenital nevus. That is the exception to the rule, but otherwise, nodules in the dermal component of a melanocytic lesion tell you it is by definition melanoma. So here's a closer view, and you can see in the bottom left-hand corner, you can make out some residual dermal nevus. And then on the right-hand side, you can see these expansile nodules compressing the connective tissue to a very, very tiny, thin strand. And that's telling you that these nodules have got a life of their own. These nodules have developed additional mutations, additional genetic problems, which have given them the ability to grow as independent populations. These are melanoma. And now, isn't that beautiful? You could just gaze at that forever. On the right, lovely maturation, that's the nevus. And here, look at those nodules. You need to, if you're very young and not experienced in dermatopathology, I want you to look at this picture on the left and imprint it in at least 6 different places in your brain. Use all of the lobes on both sides so that you have this image. And remember, a nodule like that, compressing a nodule like that, another nodule like that, those nodules, they cannot be seen in a nevus. And that's the end of it. I'll just go on because I'm getting very behind, but that doesn't matter. We can talk as long as I can and as long as you can listen. I wanted to make the point to you that a mitotic figure today is not what a mitotic figure was when I started training in dermatopathology. I started DermPath in 1973. That was the beginnings of my career. And in those days, you weren't allowed to have a mitotic figure in a nevus. Now, quite why we thought that, I don't know, because we all knew that nevi grew. And if a nevus is going to grow, cells have to mitose. And so why would we think a mitotic figure shouldn't be allowed in a nevus? It's quite ridiculous, really. Unfortunately, nowadays, we accept that you may get 1, 2, 3, 4 mitotic figures in a nevus if you've got a big nevus, and you don't need to worry about it. It's the context of the mitotic activity that matters. You find one mitosis, you see, are there more mitoses? So you find 4 or 5. And then you say to yourself, what is the context of this mitotic activity? Are there other features that worry me and suggest that this is a melanoma? Or are there features that tell me this is not something that I necessarily need worry about? It's all about context. And this is a nice compound nevus. And just to backtrack a bit, when I talk about atypical nevi being different from the banal nevus, this is typical banal compound nevus. You can see the nest at the top. You can see that the cells are getting smaller and dispersed at the bottom, so there's good maturation. And if we look at a bit closer, there's the top of the lesion. These are type A nevus cells. They have abundant eosinophilic pigmented cytoplasm. They have oval nuclei with conspicuous nucleoli. And on the right-hand side, they look rather more lymphocyte-like. They're beginning to lose their cytoplasm. So these are type B nevus cells. And at the very bottom, they're spindled. So those are type C nevus cells. So in that biopsy, we got all three nevus cell types. However, in the middle of it was a mitotic figure. And that's just to remind you and to emphasize and to make the point that they are expected in a growing nevus. They're not necessarily a source of alarm. And then I wanted to show you this case. This is courtesy of Mark Zaki, who's another great person from McKee. And he shared this case, and it's from a pregnant lady. And there were multiple mitoses, but I just copied these three images. And so if you find lots of mitotic figures in a nevus, make sure you know that the patient is or isn't pregnant before you get too worried. Now,
Dr. McKee?
Yes, indeed.
I have a few questions from Facebook and from the Zoom group chat. Would you like to answer them now?
Yes, yes, indeed.
So I actually have here a question from Dr. Kamlikova, Antonina Kalmikova, and she asked you, what do you think about re-excision of Spitz nevus? Should they be re-excised in case of positive margins?
Can I leave that question until I finish talking about Spitz nevi, because I have a whole section which we're just about to start on Spitz nevus, and I'd rather discuss that when I finish Spitz nevus. So perhaps, Antonina, if you would like to ask me that question later on, and I will happily answer it.
So there is another question regarding mitosis in a deep penetrating nevus. It says here, how many mitoses you might expect in a deep penetrating nevus? I had a 9-year-old with 4 mitoses per square millimeter. Is Dr. Basarova.
I think, again, you have to take the lesion in context. I can't really answer a hypothetical like that because it depends on the background of that individual alleged deep penetrating nevus. One of the problems is that melanoma may present with a deep penetrating nevus-like growth pattern. Now, in my personal experience, in lesions that I have regarded and have no reason to believe that I misdiagnosed them, deep penetrating nevi regularly show mitotic figures. They may show 3 or 4 mitoses. They may even show a mitotic figure in the deeper component. And you see, you've got to think about the growth pattern of a deep penetrating nevus to get the context, because deep penetrating nevi very frequently follow the pilosebaceous unit. And so if you look at the deep penetrating part and you see a mitosis in the deep penetrating part, that still may be the superficial dermis that's relative to the hair follicle along which that nevus is developing, if that makes sense. You've got to try and think of it in 3 dimensions. So it may not mean anything at all, or it may mean something. Now, if, for example, you have what you think is a deep penetrating nevus on low power, but then you look more carefully and you find that there is nuclear pleomorphism, nucleolar prominence, and that this is not maturing with depth, so that in the deep part of the lesion, you see the same morphology, that might swing you towards a melanoma with a deep penetrating growth pattern, but you still have to think about the issue that I mentioned a moment or two ago. So I can't really answer your question as a generalization, because it would be specific to each and every lesion that you look at. It's all about the context. If the lesion in every other way looks like a deep penetrating nevus, but you found 4 mitoses, I think it would still be a deep penetrating nevus.
Thank you. One more question here. I think this is quite pertinent from some people that they are faced with very pigmented skin. Dr.
Yes.
Tirumalae is from India, is asking, the biggest problem I face is that most melanocytic lesions I see are so heavily pigmented that I cannot assess the cytology or mitosis. Bleaching does not give very good morphology. What should we do in such instances?
I think the answer to that is you have to improve your bleaching technique. I used to face similar problems when I was in practice. As you know, I'm retired now, but when I was working in a hospital setting, we were able to obtain perfectly good morphology with bleach sections. So I think the problem you're facing is with your laboratory rather than the lesion itself, and they need to practice until they get a good bleach section, because you should be able to make out the morphology.
Okay, I think I'm done with the questions. We're trying to make it interactive, so that's why we're interrupting
Yes,
from time to time.
I think so.
I think that was the request of Dr. McKee, because I see some people on Facebook, they're saying, well, you should leave the questions until the end. But we're actually doing what we were supposed to do, I think, right?
I think it's better if people ask questions as I talk. Otherwise, you will forget the question. And in a way, more importantly, I may have forgotten what I was showing you in the first place, because one can't, I find it very useful to have you see, for example, this particular slide, I find this very useful to have it here now, because we can talk about it. And gosh, I'm just looking at my watch. You won't believe it's 3:15, but I think I'm game to continue on for a while yet. Are you happy with me continuing?
I am more than happy.
Okay. And
Let's go.
So let us go. Now, I think we live in amazingly exciting times. I cannot believe how the world of melanocytic pathology has changed from when I was a resident in pathology, relying solely on the clinical information and my histology. And that's why I have a little bit of reservation when people say that histopathology is the golden standard. I think molecular pathology has a huge role to play in challenging melanocytic lesions. It may not necessarily help us in terms of whether a lesion is a melanoma or not. I don't think we've quite got there, and I'll come back to that shortly. But it certainly means that we are able to talk about the same thing. And I'm going to be focusing on spitzoid neoplasms, which include Spitz nevus, atypical Spitz tumor, and malignant Spitz tumor or spitzoid melanoma. And the point that I want to make is that in a significant number of Spitz nevi, you may identify fusions involving a variety of genes listed on the right-hand side, ALK, ROS1, BRAF, and so on, BRAF, and I'll come back to those again shortly. And then we have a group of spitzoid neoplasms that we now can recognize as BAP1 inactivated nevi. And that does mean that when we look at problematical spitzoid lesions, if we have the ability to use immunohistochemistry or FISH or other molecular techniques, we can actually identify much more precisely the nature of a particular spitzoid lesion. Unfortunately, as you see at the bottom, we've still got a, well, it's less than 50% where we don't know anything about it, but at least we've got this lot where we can actually define what it is we're looking at. And I think that's absolutely breathtaking. And it's changed how I think about Spitz tumors enormously. It's changed me radically. So I recommend this paper to you all in Translational Medicine 2018. I made up this slide, and I got my friend Nima Ardakani. I sent it to him to make sure that he agreed that I hadn't made any mistakes, because I have to make the point, of course, that I am a morphologist. I'm a very simple soul with bread and butter pathology is what I deal in. I'm not a molecular pathologist. I do not pretend to be an expert in molecular biology. And so I got his help. But anyway, what I wanted to make the point is that in a significant number of Spitz nevi, and we in fact know it's sort of about 40 to 50%, say, we know that these nevi can be identified by an HRAS mutation or a kinase fusion as listed below. And what I wanted to make the point is that the tumors that we recognize as atypical Spitz tumor have the same genetic profile as a Spitz nevus, but they have something extra. They have a second genetic change, which, which alters their potential, their biological potential. It might be a hemizygous CDKN2A inactivation, or it may be a homozygous inactivation. If a patient has a homozygous inactivation, then the risk of evolution into spitzoid melanoma is obviously going to be higher. And we know that a fully developed spitzoid melanoma has all of these frequently, but it has something additional, TERT promoter mutations and so on. And then I just wanted to illustrate, this is the typical morphology of a BAPoma. And BAPomas are included, they get stuck into the Spitz nevus category, but they really shouldn't be in there at all because they don't generally look like Spitz nevus at all. So I suppose with time that'll get rectified, but many papers include them, and I stuck it there for convenience. So let's look at the next slide. And I found, again, Thomas Weisner. This is a nice paper. I like papers that are for simple souls and that I can understand. And he included this this series of diagrams with a little text showing progression from a benign melanocyte at the very top all the way through to a Spitz nevus, and tells us the driver aberrations that give rise to the Spitz nevus and what suppressor mechanisms are involved in preventing that Spitz nevus behaving badly, and showing us how we end up with a spitzoid melanoma due to the additional loss of tumor suppression mechanisms and the addition of additional genomic aberrations. And I think this is a great slide because it's relatively simple, and what it's really telling us is, on the one side we have genes that protect us, and on the other side we have genes that will do us a lot of harm. And as we progress from normal to melanoma, the genes that do us a lot of harm get the upper hand, and that's how my simple mind thinks about it. So I've lost my mouse. Here we go. Now, I wanted to show you a whole bunch of Spitz nevi. And again, many of you are seasoned professional dermatopathologists, and so I can't teach you anything about what a classical Spitz nevus looks like. But I think for the residents and the trainees and the younger folk, I think it does no harm to go back and look at classical Spitz nevus so that we have a yardstick that we're all talking about the same thing. And I'm not going to talk about the clinical, I haven't got time. So I'm just talking about the classical Spitz nevus. And this is a lesion which is often dome-shaped or polypoid, and it's circumscribed. You can't see that very clearly on this image, but typically a Spitz nevus starts with a junctional nest and it ends with a junctional nest. So you don't have a lentiginous growth going along the outside of the nevus. So it's circumscribed. And if you have the right cut, it is symmetrical. So if you draw a line down the middle and you fold one side over to the other, the two sides should match up. Now, I will admit that symmetry is not always easy, and symmetry is in the eye of the beholder. And it does depend upon you having a perfect cut right through the middle of the lesion. If you don't, it's very difficult. The other features of Spitz nevus that are particularly important are, and most important really, is that the Spitz nevus matures with depth. So, and what that means is the nest size gets smaller as you go down towards the bottom of the lesion, and the cell size gets smaller as it goes down to the bottom of the lesion. And if a lesion shows maturation, then it's very unlikely to be anything other than a Spitz nevus. So this is I haven't got the edges here, but when we think about Spitz nevi, we're always comparing the left side with the right side. And what is nice to do is to draw imaginary lines in your mind and compare the size of the nests on the left with the right. So if you look at the top, the nests are relatively large. In the middle, the nests are small, and the size of the left matches the size of the right. And when you come down to the bottom, you're down to single cells on the left and on the right. So there is perfect maturation. It is also beautifully symmetrical. And this is that same lesion. I just wanted to show you a higher power view. there are the superficial larger nests getting smaller. And this is the top of that lesion showing you the large spindle cells with vesicular nuclei, prominent but smallish nuclei, and then that's the bottom of the lesion where the cells are much smaller. And on the top right, I wanted to show you a very pure epithelioid Spitz nevus, which is a relatively uncommon variant in my experience. Most Spitz nevi are either spindled or they're mixed spindled and epithelioid, but this particular one, the whole thing was epithelioid, which was unusual. Now, I wanted to show you a series of Spitz nevi. So this is the first one. And this makes the point that it starts on the left-hand side, it starts with a nest. On the right-hand side, it ends with a nest. And this is a high power view showing the junctional component. There is retraction artifact, which we often see. There's clefting. You can make out that there's maturation with depth. The nest gets smaller as you go down to the bottom, and the cell size gets smaller. Now, to go back to Antonina's question, in this particular example, you could say to me that nest is awfully close to the excision margin. Would I recommend a re-excision because of that? Well, the answer to that is no, I would not recommend a re-excision because this is a Spitz nevus. There's nothing worrying about it. So why would I recommend a re-excision? I would just say Spitz nevus and that would be the end of it. So that, I'll try and answer that question with each lesion I look at. This is just a high power view of the same lesion. And here you see there's a cleft between the aggregate of nevus cells. The nevus cell population is discohesive. There's a Camino body there, but it's not a very good one. And on this side, you can see there's an epithelioid component with vesicular nuclei and rather more prominent nuclei. So that's a mixed case. So let's look at another one. Here's another one. Unfortunately, I couldn't get all of the slide in, but I promise you that there's no nevus this side or on that side. This is the extent of the nevus. And if we draw a line through the middle, it's perfectly symmetrical. And then I'll just see the next one. And if we look at it, that's the left side, that's the right side. There's a little bit of variability in the size of the nests, but for all that, they both show diminution in size with depth, so I wouldn't necessarily get that worried about it. And there is the top of the lesion with lots of pretty Camino bodies. There are at least 6 of them. That's the bottom of the lesion where the cells are becoming single in the very deep part. I've forgotten if this, oh, that's another one. So I would not have recommended re-excision of that one either. And this is a third case that Dr. Margarida Fernandez from Portugal shared with us on Facebook recently. And unfortunately, because of the setup, I can't get the whole lesion in, but I just wanted to make the point that this is a beautiful example of a predominantly junctional Spitz nevus showing lovely retraction artifact, discohesive cell population, and in the next slide, there you see, there's a great cluster. Whoops, I beg your pardon. What's happened? I have to go back. There's a nice cluster of Camino bodies there. So that's another typical Spitz nevus. And if I think a lesion is a Spitz nevus without any qualification, so my diagnosis is Spitz nevus and nothing else, then I would never have recommended a re-excision, whether it involved a margin or not. If I felt sufficiently confident that I was looking at a Spitz nevus, then I would call it a Spitz nevus. Now, if I have a shave biopsy and there's clearly a great chunk of the lesion not visible, I would not make a diagnosis of a Spitz nevus in the first place. If it involved a margin extensively, if the lesion just trickled and was just so close to a margin, but not, otherwise it was perfectly okay, I wouldn't worry about it. But if I was only seeing part of the lesion, I wouldn't diagnose a Spitz nevus either, because I wouldn't be able to. So maybe I hope that answers the question. This is Spitz nevus number 4, and this one again, it's fairly circumscribed and it's symmetrical, and we'll look at it a bit closer. There's the top of the lesion. I put this one in just to show a mitosis, to remind you that Spitz nevi do have mitosis, otherwise they wouldn't be able to grow. So, and these are more epithelioid cells at the top. And there's another view there of the top of the lesion. And there you can see a little bit of pagetoid spread. I beg your pardon. There's a bit of pagetoid spread, which is in the middle of the lesion. So you can get pagetoid spread in the middle of the lesion. There's a higher power view from the top of the lesion. And then that's the bottom of the lesion where the cells are clearly getting smaller. The nest size is smaller. We've even got down to single cells. So there's very good maturation. So I wouldn't worry about that one either. And I wanted to give you a little tip about maturation, and that is S100 immunohistochemistry is a great stain to look for maturation, because you can see on the right-hand side, it's a great way. I'm sorry, I'm trying to find my mouse. Here it is. Wait a minute. Yes, if you look here, you can see that the nests at the top are big. They get smaller as you go down. The nests get smaller and smaller until at the bottom you have single cells. So S100 is a great way of assessing maturation.
Dr. McKay, is there any role for P16 in diagnosing atypical Spitz lesions? Or is there any role?
I have to be truthful about this. This is something that was way after when I retired from practice. And as far as I can tell, it has a role to play, but you have to be very careful about it. It doesn't necessarily point you in either direction. You have to assess expression or loss of expression of P16 in the context of everything else that you're looking at. So if you think it's a spitzoid melanoma and it's got loss of P16, well, that's great. But it doesn't necessarily always follow that that is necessarily going to be true, and it doesn't always follow the rules. So from my interpretation of the literature, P16 is not as useful as one might have liked to have thought it would be. But other people, please feel free to comment if you'd like to express a different viewpoint from mine.
There is one more question here of Dr. Karima Sidhom from Egypt. Yes. In Spitz nevus 2, one image shows junctional lentiginous growth, which should not be the situation in Spitz nevus. What are your comments about that?
Well, It depends. If it shows a little bit of lentiginous growth, it may. It's very difficult. This, you see, one's going to get into very difficult terminology. Let me take a step back before I answer that, and it's all to do with definition. A dysplastic nevus, by definition, is lentiginous and nested. It shows architectural disorder and, by definition, cytological atypia. So a dysplastic nevus always shows a cytological atypia. Then the question is, can you get a nevus with architectural disorder, lentiginous and nested, with no cytological atypia? My answer to that is yes, you can. And that corresponds to what many authors use the term Clark's nevus for, a nevus showing architectural disorder, but no cytological atypia. So then, to answer Karima's question, can you get a Spitz nevus showing a lentiginous and nested component? The answer to that is yes, you can. And some people call that a Sparks nevus. I've never used that term. I'm not a great one for acronyms and making up new terminology. It confuses me no end. So I think, yes, you can. If it showed cytological atypia, then it would be a combined Spitz nevus and dysplastic nevus. That would change one's interpretation considerably, because one would have two different diagnoses in the one specimen, and one would have to think about that lesion in two different ways. One, you'd think about, is this a Spitz nevus or does it worry me? And secondly, is this a dysplastic nevus? Yes, it is. Is the atypia low or high grade? Yes, it's high grade. Does the atypia involve a margin? No. Okay, we don't worry about it. Does it involve a margin? Yes. Oh gosh, we have to get it re-excised. Does that answer the question, Karima?
I think it does, Dr. McKee.
Okay, I'm going to talk. Now, this is I am obliged to talk about this lesion. I have to be truthful, and all of you who know me and know me well know that I hate this entity. I always have, and I have good reason. I shall make my case. In children and young adults, melanoma is exceedingly rare, and therefore a spitzoid lesion in a child or a young adult, a teenager, is almost certainly going to be a Spitz nevus, nothing more or nothing less. Now, I do accept that one may get melanoma, albeit exceptionally rarely, and that melanoma may show a spitzoid morphology. And if it does, I would call that a spitzoid melanoma. And that, in days gone by, that was how I was trained, and that was the way it was for many, many years. And then we had a combination of two things. One of the problems that came up was, I think, particularly related to the nature of the specimen that one received. And that was the problem that one was receiving partial biopsies. And because of that, one was having to make a diagnosis on an inadequate specimen. So that was a big problem. And then the second problem was that when we looked very, very carefully at spitz nevi and started to assess different cytological features, we ended up with this list of morphologies that might or might not concern us. So I haven't got them listed here, but I think I have them somewhere else, but I'll talk about them here anyway. In a spitz nevus, pagetoid spread is restricted to the middle of the lesion. If you start seeing pagetoid spread extending out towards the lateral component of the nevus, then it's less likely that this is a spitz nevus and more likely that it's going to turn out to be at least an atypical spitz tumor, if not a spitzoid melanoma. Everything is dependent upon context. So that's pagetoid spread. What about mitoses? Mitoses at the top do not worry me. Mitoses at the bottom do worry me, but it would depend upon the context of a particular lesion. If, let us say, it's a 3 millimeter diameter spitz nevus from a six-year-old child, and I saw 2 mitoses at the bottom of the lesion, and nothing else worried me, then I wouldn't worry about it. I'd call it a spitz nevus. But other people would say 2 mitoses in the bottom of the lesion, that makes it an atypical spitz tumor. So we have a difference of philosophy, a difference of terminology, a difference of how we view these lesions. The problem would be made very difficult if we only had a biopsy and we had 2 mitoses at the base of the biopsy, but we couldn't see the rest. Then I fully agree. I won't call that a spitz nevus. I would say this is a spitzoid proliferation and we need to see the whole lesion before we can decide whether it's benign or malignant, which in a way is my way of saying the same thing. It's just I avoided using the term atypical spitz tumor. Why do I avoid the term? I avoid the term, or I have avoided the term, largely because it causes problems for the patient, for the clinician, for the aftercare of the patient, and for you as the pathologist. Because if you become too comfortable with atypical spitz tumor, what tends to happen, and I've witnessed this countless times, is that pathologists start losing confidence in their ability to recognize a completely benign spitz nevus, and they increase the proportion of cases that they put into atypical spitz nevus or atypical spitz tumor. And as I've mentioned, some people, if they found 2 mitoses in the bottom of a spitz nevus, they would automatically put that into atypical spitz nevus, atypical spitz tumor category. I would not do that if I didn't have other features that would concern me. From my perspective, it's all about context. A spitz nevus does not show effacement or consumption of the epidermis. It may show traumatic ulceration because it's a child that may pick at it, and that's always a bit problematic. At least I find it difficult sometimes to know which I'm looking at. But if the epidermis is intact, effacement, consumption is something I do not want to see in the spitz nevus. I mentioned the pagetoid spread. I have talked a lot about large nodules. So large nodules in the dermis worry me enormously. Loss of gradient of HMB45 and Ki67. I'm going to show you on a slide that this is a bit, I'm rather ambivalent. I used to think HMB45 loss of expression with depth was invariably something one saw in a spitz nevus, and if one didn't lose it, that shoved one towards melanoma. But that may not necessarily be the case, particularly if it's from a young patient. And this example here that Antonina Kalmakova shared with me has a very interesting HMB45 expression I'll show you. Now, Ki67, you have to be careful with Ki67 because the problem is it lights up lymphocytes as well. And so when you're looking at the dermal component, you got to make sure you're not identifying lymphocytes rather than nevus cells. I've never thought really so much about percentages. Just suffice it to say that if I see a lot of Ki67 and I'm convinced it's in the dermal component in the deep part, that would cause me a lot of worry and I'd be much more concerned about it. So let's look at Antonina's case. There we see, you see, this is if you like, in a way, this is what Karima was talking about. If we draw a line through the middle of this, it looks really, I mean, I apologize for this artifact, but it's because of the blocks slightly cut through before the case got scanned. But if we draw a line through the middle of this like that, it's very symmetrical, but it's not circumscribed. There's a lentiginous component there, and there's a lentiginous component there. So we can't call this circumscribed, but it's very spitzoid. There's tremendous clefting. If we look there where we're clearly not looking at this artifact, there's beautiful clefting. The cells are very discohesive. Now, this is the left side of the biopsy. And here you can see this lentiginous growth at the edge of the lesion that Karima was worrying about. And here we see the bulk of the lesion. And if we look at the next slide, we look at the other side. This is the right-hand side. And again, we've got this lentiginous element, so it's not circumscribed. And what I wanted to notice was these nests at the bottom of the lesion. Most of this is junctional. It's quite hard to tell which is which, to be honest with you, but we'll see that better in a moment. That's through the middle of the lesion. And what I wanted to look at was here. This is showing you the top with large nests. And a rather worrying cytology. The nuclei in places are very hyperchromatic and irregular. And I suppose that would cause you some concern. I'm not sure how much, mind you, but it would cause you some. Now, but this is what I wanted to show you. You see, this is HMB45. Now, if we take HMB45 as being something which tells us loss of HMB45 expression equates with benign spitz nevus, then you would say, oh gosh, HMB45 is expressed throughout the lesion. So that's worrying. But on the other hand, HMB45 is showing us beautifully this lesion matures perfectly. There are the nests at the top, huge nests, I agree. There are the nests in the middle of the lesion, which are much smaller. And there's the bottom of the lesion. small cells. So on the basis of the HMB45, I'm quite comfortable that this is a Spitz nevus. And that, if you like, is I'm going against what is commonly taught. But I think this particular image is so striking that it shows, to me, that's a Spitz nevus. Now, what have I got? I'll show you this last case, and then I'm going to stop because we're nearly 2 hours. So this is the last case. This was a child, and I don't know where this came from. It was shared with me by Professor Wayne Grayson, and I was living in Sedona, Arizona at the time. So that was, gosh, probably at least 12 years ago. And I don't remember anything other than it was a 5-year-old child with a lesion that had been biopsied and was thought that it might be a Spitz nevus. And the point that I want to make is, yes, it looks symmetrical and it looks circumscribed, but if you look at the left-hand side population of cells and then look at the right, they're different, aren't they? These are bigger, the cells are bigger, the nests are bigger. So that and that are different. So in fact, if you look at it carefully, it's asymmetrical. It's not symmetrical at all. And if we look again, compare the left, whoops, hang on. If we compare the left side, which are rather, the cells are bigger, the nuclei are bigger, and here they're much smaller. They look as if they're maturing nicely on this side, and on this side they're not. So there's something very worrying going on. And this is the right-hand side to show that it does mature. And this is the left-hand side to show this is deep. This is the depth of the lesion. That's the depth of the lesion. It's not maturing at all well. And there's a superficial mitosis. There's a mitosis in the middle of the lesion. And there's a mitosis in the deep part of the lesion. There's a mitosis. That's actually in the deep part of the right-hand side, the bit that I thought looked as if it was maturing. There's a mitosis right at the bottom. That's the absolute base of the lesion. And there was lymphovascular invasion all over the place. It was just everywhere, everywhere. And this is HMB45, which is quite interesting because although it's expressed throughout, it does highlight in this area here that there is maturation with depth. So again, I make the point that HMB45 can be a bit misleading. This is key 67. These are all melanocytes, just teeming with key 67 positivity, and there's CD31 expression. So that was diagnosed and thought to be a spitzoid melanoma, and I don't have any follow-up, so I can't prove to you whether that diagnosis was correct or not. So this is my last slide, and I think this is a very important slide because when we're thinking about Spitz nevus versus atypical Spitz nevus versus spitzoid melanoma, most of the, well, no, I'll rephrase it. Some of the criteria that we use for defining atypical Spitz nevus are the same as some of the criteria we diagnose for spitzoid melanoma. And it's all about the context. The more asymmetrical, the more poorly circumscribed, the increasing mitotic activity, the increasing pleomorphism, and so on, they all take you from Spitz towards atypical Spitz, towards spitzoid melanoma. And in this case I've just shown you, there was asymmetry, there were large nodules, there were numerous deep mitoses, high Ki67 expression, lymphovascular invasion. So we made a diagnosis of spitzoid melanoma. I don't know what the outcome of that patient was, so I can't give you a final diagnosis. And I think this is where I want to stop, because I'm going to end up into a whole new section. So I'm very happy. What I'll do is I just have to close this. Yeah.
Do we still have some time for a couple of questions
Oh
from?
yes, we have. I just
there
want
is the silent majorities in
hang on
Facebook.
if you just give me a second, please, until I want to get rid of this PowerPoint. That's it. So I'll close PowerPoint.
So the people from Facebook, they were asking, oops, can you hear me?
Yes, I can hear you.
The people from Facebook are asking you, does age have to do anything with the excision margins in Spitz lesion?
I'll tell you what, before you can ask me that again, can we go back to screen sharing so that you and I are visible on my desktop? Can you fix it that there's
Let me look. Okay.
And then you can ask me the question. Because I want to be able to see you or perhaps other people. If it's too difficult, doesn't matter. Ask me the question again, and while you're fiddling, I'll try and answer.
Yeah. So the question was, here we go. Multiple people can share the screen simultaneously. Now, I think people in Facebook and we are all seeing you. I can see the people in Facebook. I see some people that are familiar to me.
All I can see is you.
Oh, okay.
I can't see anything else. I wanted to see other people. It's exciting.
I think you are co-host.
I am. Let me just see if I can, if I stop sharing.
Yeah.
Should I do that?
Yes. Now you can see me. But now people are seeing us. They're not seeing the presentation anymore.
No, I can. Well, there isn't anything more, but I can see lots of people. This is great.
Okay.
So what was the question?
So people from Facebook were asking you, does age matter to you when you diagnose a Spitz nevus with, let's say, positive margins? Another question was, does any Spitz with...
Let me answer that first question. Does age have an influence with me for a Spitz nevus that's showing positive margins? The answer to that is no, because if the margins are positive, that means I haven't seen the whole lesion. If I haven't seen the whole lesion, I'm not going to diagnose a Spitz nevus. So that's the problem. The problem doesn't go away. What I would say is that I don't think I've ever personally diagnosed a Spitz nevus in a patient age 50 or 60 or 70. It would be unthinkable. I'm sure someone has described one. I'm sure they have. I don't know whether I'd believe them or not. But I suppose if I was to look at it slightly differently, supposing I have a 6-year-old with a biopsy, with an excision of a lesion on the cheek that is clinically a Spitz nevus, and it just extends to the margin. So excision is just about complete, but not totally, it wouldn't worry me in the slightest. No, I wouldn't. And if it was a 20-year-old, it wouldn't worry me either. If it was a 30-year-old, it wouldn't worry me, I don't suppose. Getting older, I start getting more concerned because my threshold for diagnosing Spitz nevus diminishes with increasing age.
I see.
So again, I can't answer that question precisely unless I have the case in front of me, but those are generalizations that I would make. You'll have to excuse me, but I'm going to be sucking a Nicorette tablet because my nicotine levels are getting very low, which is very bad for me. Next question, please.
Now, there is a question regarding Spitz nevus with mutations. Do you have any particular concern about the margin with those lesions?
I didn't understand the question.
So did somebody ask here, if you have a Spitz nevus with kinase positivity, like
oh yeah, it would like an alcoma or a
exactly.
No, it doesn't make any difference. You see, that's the whole point of it, isn't it? Really, I can't quote chapter exactly, but somewhere between 50 and 60% of Spitz nevi are going to show an ALK fusion expression. They're going to show ALK1 or ROS1 or whatever. So that doesn't tell you anything different. It doesn't tell you whether it's a Spitz nevus or an atypical Spitz nevus or a spitzoid melanoma, because spitzoid melanoma will, in a significant percentage of cases, show exactly the same fusions. So no, I just because a lesion is an alcoma, or as we'll discuss later, a BAP1 inactivated nevus, you don't necessarily need to re-excise it, because it's, if everything else says it's benign, then it's benign. It's a Spitz nevus.
Another person asked, in basically a typical nevus, do you have a threshold to order levels?
Do I have a threshold to order levels?
To perform other histologic levels?
Yes, I suppose the system that worked in my laboratory was that one routinely got a lot of levels, and we kept slides aside for immunohistochemistry. So I might get, from one case, I might get 6 levels in the initial sign out, with saved sections in between those levels for immunohistochemistry. So in a way, I already had my levels. So if you only have one H&E, yes, I would advise you do levels, sure, absolutely.
Now, I think this is a dermatologist, Dr. Alice Roberts.
Oh, I know Dr. Alice Roberts very well. She's a lovely lady.
How quickly can Spitz nevi come up? How rapid is too rapid?
Gosh, that's a wonderful question. I have no idea. I don't know the answer to that because I'm not a dermatologist. I think, again, it depends upon the age of the patient. I mean, how long is a piece of string? How long, if it's a 6-year-old child and it's a lesion on the cheek, I don't think, I don't know. You must have a good reason for asking that. So tell me why you asked that question.
Well, there is another question in Facebook here. This is the chat. This is the chat from her as well.
Okay.
Is there an age at which it will be prudent to be very careful before diagnosing Spitz? And in brackets, show another dermatopathologist.
Yes, I think once you reach the 30s, you should always show a Spitz nevus to your colleagues. Well, in fact, to be honest with you, unless you don't have any colleagues, that's if you're a single person, you can't go sending every case you get off for consultation, or you'd never get any work done. But by and large, if a lesion is absolutely, if you're absolutely happy and you are experienced, that's important. You've been doing derm path for a while. You're not a novice. You're experienced, and you see it in the second, third decade. Well, why would you need to worry about it? If a patient is 30 plus, sure, you should show it to your colleagues if you have any. If you're on your own and you're not comfortable, send it for consultation. And that's the beauty, you see, I think, of the situation we are now in with social media, and not just McKeederm. There are dozens and dozens of sites where you can show your cases in a very safe environment. You take as many photographs as is necessary. You post them, and provided you're showing images that are representative, then you can get a lot of help. If you're able to scan the slide and show this, let someone, myself or somebody else, look at the scanned case, that's even better still. So we're changing, the world is changing enormously, and the need to send the paraffin block and so on and so forth is becoming much less. I'm not saying you don't, sometimes you have to have the glass slide. Sure, I'm sure you do. But nevertheless, I think for the overwhelming majority of problem cases, you can share that case with so many other people. I mean, for example, we see cases on McKeederm, problematical Spitz lesions, and you'll see 100 opinions, and you can work through the opinions, and you know who the melanoma pathologists are, because, well, you just do. So you can look at people whom you know are recognized authorities, see what they think. And if they think you're talking rubbish, then you're talking rubbish, and you need to amend your thinking and report it in a different way. So I think everybody should take advantage of what's on offer. And that way, the chances of you making a serious mistake either way, benign versus malignant and malignant versus benign, if you take advantage of what is available for case sharing, the chances of you making a bad mistake are very much reduced.
There is one more question here from Sabrina Sadaf Wagar. I'm a clinical dermatologist. I observe mildly dysplastic nevus and always re-excise moderately dysplastic nevi. What are your thoughts on excising moderately dysplastic nevi versus observing them clinically with regular skin examinations?
Well, the problem is, I'll tell you what the problem is, and this is where the WHO have really, really confused the issue slightly. I am going to listen to the WHO, but the trouble is they changed the grading system for dysplastic nevi. And so they now have low and high grade dysplasia. Mild dysplasia is no longer considered dysplastic at all. And so you have low grade and high grade. And low grade is essentially moderate cytological atypia. High grade is severe cytological atypia. Now, I suppose I will respond to this in two ways to the dermatologist. Why, if you were worried about the dysplastic nevus, why didn't you use, if you're using a punch biopsy, why didn't you use a punch that was one size bigger to ensure you got the lesion out completely first time round? Are you able to answer that? Can we get a reply to that?
I'm waiting. It's they're typing on Facebook. So I think it's going to be difficult to get an immediate answer. They have a 20-second delay. That's usually
That's
what
okay.
happens.
We can wait.
So again, is Dr. Sabrina Sadaf-Wagar.
Yeah. Well, while we're getting a reply, I'll tell you my experience.
So it's saying here, I typically complete saucerized shaves.
Okay. Well, then you've obviously done the best you can do. So generally speaking, you should not encounter this problem so often, but you still will encounter it. Now, this is the situation when I was practicing in Boston, and a mild atypia involving the margin. In the old terminology, I would not have recommended a re-excision. I would just say follow up carefully. Moderate cytological atypia, which is now we call low-grade atypia, I suppose it depends really on how involved the margin is. If you have one or two cells that are just trickling towards the margin, but that's the height of it, you probably would be quite safe to follow the patient up carefully. I'm not sure that re-excising would actually be of any great benefit to anybody. If it was really involving the margin significantly so that you were definitely not seeing the whole lesion, then the routine that I followed was to recommend a re-excision with 2 millimeter margins. If it was severe cytological atypia, I treated that as the same as melanoma in situ, and so we recommended a 5 millimeter margin. Now, those are all generalizations, you see, and they don't take into account specifics. And I think it's important, if it's at all possible, for the dermatologist and the dermatopathologist to establish a very good communication with each other, so that perhaps they might even discuss a particular lesion so that they know how worried the dermatopathologist really is. Because I've always felt that we should try to keep re-excisions. We should try to exercise on the low end of the scale if it's possible. We should try to avoid a re-excision unless it's really necessary. And sometimes communicating with the dermatologist, if the dermatologist says to me, well, I excise that lesion and I am confident that I had a 2 millimeter margin all the way round, and my cuts show that it just extended to an inked surface, I might say to the clinician, well, that's fine. Follow the patient up. If it recurs, re-excise it. If it doesn't, don't do anything. Because here's the problem. The problem is we're making assumptions for which we don't have proof. We made an assumption many years ago that a mildly atypical, a dysplastic nevus with mild cytological atypia was better than a moderate atypia, which was better than severely atypical, which was better than in situ carcinoma. Now we know that there is molecular overlap between severe cytological atypia and in situ melanoma. We know that there are genetic aberrations common to both. but I don't know necessarily whether we can say that's true for dysplastic nevus with moderate atypia. But we use those 3 grades of atypia to guide clinicians, rightly or wrongly, in terms of re-excisions. So we, in a sense, we created the re-excision phenomenon ourselves by virtue of the biopsy techniques that the dermatologists used to present us with the pathology. It was a self-generating outcome. Incomplete excision equals re-excision. And it went round and round and round in a circle. And it was partly our fault, partly the dermatologist's fault. But if we talk to the dermatologist about a specific lesion, then we probably can reduce the number of re-excisions we recommend. Does that help?
Yep, very much. So, Dr. McKee, are we going to continue next week?
I think we should. I think, let me just think. I think next, you know, the awful thing is, I don't know when this is going to end, because I got to about a third the way through. We may end up having 2 more lectures on benign lesions. I hope people don't mind, but I reckon it's better that we spend a long time and look at as many examples as we can, so that we cover the topic in depth. And I want to say to the participants, it's very important to me that you ask as many questions as you like, because that's why I'm here. I'm here to answer questions, and it's equally important to me that you, if you disagree with me, you must tell me so and tell me why. I don't set myself up to be a golden standard. All I do is I set myself up to be what I am. And I know that other dermatopathologists will take a slightly different view on some of the topics we discuss. I respect their opinions. They do influence how I think. They have influenced how I have thought. And but I've ended up the way I am because I've done dermatopathology now for, let me just 27, for 47 years I've been doing dermatopathology. So that's my credential. But you know, that's 47 years of H&E and a little bit of immuno thrown in. I'm not a person I've never ordered fish in my life. People do it nowadays, but it didn't exist when I was around. There was no such thing as fish.
Any comments from somebody else, or
yeah?
Any questions from the audience in Zoom? Okay, so Dr. McKee, I think it was a brilliant lecture. We're going to plan then to continue presenting next week, Saturday, same time, if you have time.
I do.
And we're gonna keep on going until we finish this lecture, but you owe me a second lecture, so I don't know how long we're gonna be doing this.
Maybe a second or a third. Well, I just want to thank everybody and to let you know I am recording this. The problem is it's going to be an enormous file, probably 120 gigabytes. It's going to be enormous, but I hope that it works, and I will share it. I will stream it live eventually from my YouTube channel, and I hope that it's all worked properly. I've enjoyed myself immensely talking to you all, and I hope you've had fun time too, because this is meant to be fun. So thank you very much, and bye-bye to all of you. Thank you.
So this will be everything. I think I'm gonna close the
if you close the meeting now,
meeting, and I'll thank everybody for participating. There were people from all over the world, and hopefully I'll see you again next week on Saturday. Have a good day.
Can you minimize the screen then, please?
Yeah.
Because I can't stop recording until you've done that.
Good.
Can you close it?
Yep. I'm gonna end the talk. If you want to talk to me,
Yeah,
you can.
yes, please end it now.
Yep.
Because I can't